Thank you very much. First of all, great listening to all of you, and very grateful for the invite. Uh, my association and connection with the HIV global story is in its timeline is very interesting in that many of us of our generation and cohort encountered this as an incurable disease. I arrived in the US in the summer of 1989 as an intern, and HIV then was virtually a death sentence. We had one medicine, monotherapy, unbelievable today, but that's what it was. And that was what was used at that time. In fact, this continued all through my residency and all through my fellowship years. In fact, during residency, I'd say at least a third of admissions were HIV and its complications. And I came back in 1995, and having left a lot of my people, my patients through clinic, inpatients, etc., suffering through this disease, which really no one could improve other than just treating opportunistic infections. I returned back exactly a year later to attend one of our primary infectious diseases meetings. And it was as if the world had changed. All those that were dead or dying and near death started to reverse. It was almost a scene out of the movies. So my personal journey has seen this, and within Pakistan, then we saw a similar transition as more effective therapy became available. Back in the mid-90s, it was available elsewhere, but within Pakistan, it was prohibitively expensive, and we saw a turnaround of that when some of us got together to make centers for HIV care. So a little bit about that in a bit. So Pakistan, like many developing countries, has numerous health challenges and societal issues that relate to controlling the spread of HIV. Now, these, of course, and COVID-19 recently hasn't made things any easier, but it's actually given us a lot of opportunity to retool and to find methods and opportunity in adversity. And I really truly mean it, and I'll share some thoughts with you on this. Now, where do we stand today? As best as we know, we estimate the prevalence or the point prevalence of HIV based on sizes of various at-risk populations and the prevalence within them. So, for example, if we were to look at MSM, so the estimate of the population in Pakistan is 800,000, and 3.5% of them are supposed to have HIV. So that's the prevalence in that group based on data on samples, and that means that the total number is about 30,000 for the country, and so on. So this number varies as high as those with use of injecting drugs, a 38% point prevalence to as low as 2.2% in female sex workers. And these are very telling statistics, and we'll talk a little bit more about it. So some of the key issues have been already highlighted and spoken about, but I'd like to really throw some light and focus and special focus on those areas where we think the biggest problems are. If you look at some of the outbreaks within Pakistan, they are highlighted. They stand out by the contribution of those in those outbreaks that are not necessarily in an age or a group that would make sexual transmission the likely scene. So iatrogenic transmission, we feel, is at least half of the story. Injecting drug use, perhaps about a third, and in some situations, both these pathways are in effect. As far as these so-called outbreaks are concerned, and I agree with Bushra, I think perhaps these are not outbreaks. We're just discovering what we do find where we look. And so in many of these outbreak-like situations, none of them seem to be solely attributable to sexual transmission, although certainly it's been added or it is added to the mix. So fundamentally, it's been either iatrogenic or injecting drug use. Now, unsafe healthcare practices, poor infection control. We've talked about multiple outbreaks. 5 out of the 7 major outbreaks have had at least this as the major contributing factor. Jalalpur in 2008. Jalalpur, I had the opportunity of seeing virtually all of the the initial detection was 88 patients, but eventually we ended up seeing over 200, 250 individuals. And so we saw what it did. And fortunately, just around that time, the availability of effective HIV antivirals was becoming a feasible option. And so many of these individuals have lived to tell the tale. Now, the other problem is the high use of, so it's not only that it's the setting is iatrogenic, but that compared to the rest of the world, we seem to like to have a lot of injections. So the number of therapeutic injections that a Pakistani uses per year is significantly higher than the global numbers. And there are some extrapolations, but nevertheless, it seems like 1 in 3 persons might receive an unsafe injection every year in the country. And so all the strategies that we need to come out with have to actually address these and address these unsafe injections and so on. So the policies and procedures, teaching, training, funding is crucial. So far, in terms of national strategies, we've depended a lot on a global fund and other external funders, which is fine, except that when the country does not put its own money on the table, the seriousness that is expected out of implementation often goes lacking. And as we just mentioned, we're living in today's world where even in very limited settings, good effective treatment is available. It's cheap. In Pakistan, it is free. And I can tell you that all those people who remain reasonably adherent to treatment remain free of advancement of the disease. So this is really the cheapest way, not only to take care of the individuals, but also as a method to prevent further spread of the disease. So at the present time, we've got about 49 antiretroviral ART centers with 45,000 registered HIV patients, but only 25,000 of them are on treatment. So here's the dilemma. You heard from the previous speaker, this therapy, once on board, essentially acts as a preventer as well. But we are only able to get just over half of our people on therapy. And I can tell you that this number has increased very significantly. Until 2 years ago, it was even lower than this. So this is one of the issues. Anyway, these centers do provide registration, HIV testing, treatment, counseling, and of course they track loss to follow-up, etc., and do viral load testing. Of all the disease-specific vertical programs, I can tell you that this has been a pretty good program with a lot of acceptance amongst the population. But the only thing is, what's been highlighted earlier as well, to get everybody in. So if we have 50,000 people registered approximately, we are clearly missing out another about, at least 50,000, perhaps more. And so if we do not attract them, then we are missing them out. And the primary reason is what was mentioned already, that the perceived stigma and the fear of marginalized people who do not even have the confidence of coming in and thinking, well, we'll be treated reasonably, contributes to this. That brings up the importance of community-based organizations that actually deal with key populations, and they have registered, nearly 85,000 MSM, 34,000 transgenders, around 20,000 female sex workers. So they've got a reasonable arrangement on how this works, but nevertheless, a lot more needs to be done out here, because without this, you're not going to be able to reach those key special populations for whom it is not so easy to just walk into a hospital with confidence and say, well, we'll get care and treatment with dignity. There are some interventions at the primary healthcare level, which we are trying to put together as part of a universal health package. I cannot go into too much detail into this, but unless that is done, really, a lot of the other interventions, including HIV, will not help. Dr. Bushra laid out the fundamental directions of the first, second, and third strategic frameworks, and though they moved from initial sort of detection and prevention to interventions in key populations and eventually into HIV treatment and care, especially as 0 = 0 became well established. Although I think some of us in this world of HIV care knew this, or at least intuitively and eventually through experimental evidence quite early on. So there are, important challenges as well. So stigma, we have mentioned. The changing demographics of HIV patients is a bit of an issue. So this FSW population used to be a fractional number. It used to be about 0.2, 0.3%. It's gone up to 2%. And the inaccessibility of some of the special populations, especially people like the transgenders, the hijras, and so on. We have a fairly large number of people lost to follow-up, and that's something that needs to be done. Governmental spending, I've mentioned already. And the other thing that we have not been able to do, embarrassingly, and I intend to do this, this is a little bit of a personal venture for me, is to get OST initiated, and opioid substitution therapy. Some of our narcotic control organizations get very jittery about this, and we're going to use our present reach and influence into the system to hopefully change this. The reuse of syringes, perhaps up to 30% or more in primary care or general practitioner settings, is, I think, at this time, one of the main drivers of this outbreak. So going forth, we really need to increase spending, and you will see this coming out of PC1s and increased allocation in some of these programs to prevent harm and reduce HIV, hepatitis, and other things. And all these, as you know, are cross-cutting. Reduction of stigma is crucial. And as was just mentioned, I think this has moved from more a biologic problem to a behavioral science problem. And I think this really needs a sociologic and behavioral approach to it. One crucial area that we really need to address is unsafe injections and blood transfusions. And we have therefore this year, you may have heard, but as of this year, after the first quarter, there will be only auto-destruct syringes that will be imported in. And after the summer, only auto-destruct syringes will be manufactured locally. So we are transitioning from reusable to auto-destruct syringes, and we do feel that this will have a significant impact into sorting this. Lastly, we've redone the National Institute of Health. The NIH Pakistan has existed for decades. We've changed the act through ordinance, through an executive order. We've actually got the act right now currently being navigated through the legislative framework. It has a completely new private sector board with only 2 governmental representatives, 7 top-line professionals from public health, epidemiology, infectious diseases, research, and so on, to lead this, and with additional funding. It has a new Center for Disease Control, which of course will be crucial in controlling many of these infectious diseases. And in fact, one of the institutes is the National Health Data Center. We've living in the times of COVID, very briefly about this, it hasn't helped to have one massive challenge of once in a century challenge, while we're still struggling to deal with many of our usual challenges like HIV, like polio, and so on. But I think one of the things that has helped us is to be able to have a data-driven, focused, coordinated response to COVID. I really think that we are in the midst of our, in our third wave, which seems to be coming down, at least in the northern half of the country. And so I think any success so far, and we say this with great humility, but any success so far has been because of a lot of coherent, data-driven, coordinated response. And I think as we ramp up our vaccination campaign, hopefully we'll see the end of this at some point or the other in the next coming few months. So I'll stop here. HIV remains a serious challenge for me as an infectious diseases physician and as a practicing, until a year ago, practicing clinical infectious disease doctor. This has been something that is close to my heart. And I do feel that we do have the opportunity to really turn the numbers around, which haven't happened so far. And I've shared with you some of my thoughts on what the strategies ought to be. I'll stop here. Thank you very much.